When a patient comes to clinic with a suspected extensor tendon injury, the clinician will perform an examination of the hand to assess the function of the tendons and look for other injuries such as nerve or blood vessels in the hand. Sometimes you will need an X-ray if we're worried there is any contamination like glass or metal in your hand. Some patients will be offered an ultrasound scan to have a look at the tendons in more detail, but not everyone will need one. If the assessment suggests you've had an extensor tendon injury, your clinician will probably offer you an operation to examine your hand and finger structures and repair your tendon. According to the British Society for Surgery to the Hand, open extensor tendon injury should be repaired within 4 days of the injury. So your operation may not happen on the same day you're seen in clinic, and you might be asked to come back to the hospital in the next couple of days. Whilst you wait for your operation, you should keep your bandage clean and dry. You will probably be given antibiotic tablets to protect against infection, and you may need a tetanus booster vaccination. You'll be asked to come to the hospital on the morning of your operation, where you'll meet the surgeons doing your operation and sign a consent form. It's protocol for us to mark an arrow on your hand or arm to indicate the side you're having an operation on. This is an opportunity to ask further questions you may have about your operation. Before your operation, you will also meet the anaesthetist. You may be offered a local anaesthetic, which are numbing injections given by the surgeon to numb the hand and fingers so you can't feel the operation. A regional anaesthetic, which is a numbing injection given into your shoulder by the anaesthetist to numb your entire arm. It feels a bit like a dead arm, or a general anaesthetic where you'll be asleep. This is a decision the anaesthetist and surgeon will make and discuss with you based on what is best for you and your injury. In the operating theatre, your arm will be cleaned and the rest of you covered in blue drapes to make sure the area we're operating in is sterile. The surgeons will wear sterile gowns and gloves and probably magnifying glasses called loupes, which help us see delicate structures up close. The surgeon will need to identify both ends of the cut tendon and may need to make further cuts in the finger and palm of the hand to see and to find the structures they need. Once the two ends of the tendon are found, they are tidied up and repaired with surgical thread using special strong locking knots. In some situations, if a large chunk of tendon is lost, the two ends may not be long enough to join, in which case your surgeon will discuss other options with you. Once the tendon is rejoined, it is tested on table to make sure it moves properly and sits together well. The hand will then be washed and the cuts closed with stitches. Your surgeon will place a plaster cast on your hand and wrist, which prevents it from moving or immobilises it. This is done to protect the repaired tendon as it heals. When it's newly repaired, it's at a higher risk of snapping or rupturing if it's overused or put under too much strain. The plaster cast holds the hand and fingers in a safe position whilst the repair strengthens.